a 64-year-old lady who was diagnosed with hypertrophic cardiomyopathy with NYHA class 3 symptoms for 5 years ago. And she has now developed severe heart failure in spite of maximum tolerated medications, including right heart failure. Our echo done recently, which I'm going to show you, shows a gradient of 106. And she also has severe mitral regurgitation with systolic anterior motion leaflet. So it's a very complicated case with MR plus HOCM. There's a systolic anterior motion of the anterior leaflet, turbulent jet across the LVOT, thickened interventricular septum, and there's also a posteriorly ejected MR jet. Interventricular septum measures about 18 millimeters, and then you can see the gradient over there is about 3 to 4 meters per second. The right coronary artery is normal, and we are looking for a good septal perforator. And what you can see here, there's a bit of a problem. The first septal perforator is very small, but the second one is a bit big. It's probably the only target that we can do. So that's actually what I'm going to focus on. You can see on the left side a screen which shows all the characteristics, the spike and dome appearance of the aortic tracing, the Brockenborough phenomena where we see a post-tectopic decrease in pulse pressure with a spike and dome increase and a significant increase in the gradient. And the same over there over on the left side, on the right side shows you the pullback, that there's gradient is at the level of the LVOT, not at the aortic valve. We have an access to the right arm, we have right radial artery. We have IJ for a permanent, for a temporary pacemaker wire. So we're going to do radial. I took a GR4 and advanced the catheter into the LV. There's significant LVOT obstruction with the left ventricle pressure of 250. And I'm actually going to do a pullback tracing, and you'll see now that the LV is going to come down, the pressures will drop. It is actually, LV has dropped very significantly, because that's near the LVOT, and see there's LV pressure, it's 119. And then when I pull back into the aorta, there's no gradient between the LVOT as well as the aortic LVOT. So we've given heparin. Well, our goal is to do an alcohol septal ablation of the first septal perforator. And if the SAM doesn't improve and the MR is continuously severe, then we will consider doing a mitral clip, thickened interventricular septum. I'm going to use a CLS guide catheter to engage the left coronary artery. And if that doesn't engage, I'll use a CLS3 if we have one. Forgot to check the MR grade, but it's okay. Mild sedation, that's right. Sedation, yeah. And you're avoiding propofol, correct?
Correct, yes.
So I'm using a CLS guiding catheter. I'm going to engage the left. I personally do all my alcohol ablations through the radial artery and not through the groin. And I put the pacing wire through the neck because there's about a 5 to 10% chance the patient will require a pacemaker so that the patient can ambulate after the procedure. So I'm just going in with the CLS. Can you put this on? Now let me just get this into the guide. Okay, good. I'm trying to get access to the guide catheter. No, don't take it out. I'm just having a little problem engaging the left. Can you test, please? You probably need a 3 CLS. Yeah, let me just try one more attempt. No, I think it'll be difficult to get this. Okay, just can you get the wire? We're having a little bit of a problem getting the guide in. Let's take one more try. So there's a bit of a challenge in the guide catheter. I'm pulling it back, trying to put it at the left cusp, and then trying to go up. And I think the curve is not enough there. All right, so let's just exchange this out. Let's try a CLS3. So once we get the guide in, we'll decide what sort of septal perforator we are going to use. As you can see, I put a temporary wire right side in the RV apex, which is in a nice position. It's going to increase the curve to keep a good curve there. Okay, good. So I go here and then like that. Can I test? Okay, good. Take a deep breath, test. Good. Breathe normal, that's good. So we got a nice access into the left coronary system. I think the pressures are okay. So just damping a little bit. Yeah. That looks good, actually. I'm just going to make it more coaxial. There's a bit of damping of pressure, and I can't understand why. Let me just get it back a little bit like this. And this is a small picture I'm just taking of the areocranial. And you can see there's a very small first septal perforator, which is very tiny. And the second one is bigger. So can you see that? So I'm going to try to see if I can get into the first one. And if I can get into the first one, I'll take it. If not, I'll go through. So get me a 2 millimeter balloon. Pull the wire back. Pull the balloon back. Pull the wire back. Pull back more. Good. So we got an over-the-wire 2 millimeter balloon, and I've taken a BMW with an extra curve, and then I'm just going to go in, and if we can't get it with this, I might try a whisper wire. I'm going to see whether I can get the first or the second perforator. I'm not sure which one I can get. So I'm in the one of the perforators now, right? Okay, good. Let's get the guide inside better. Okay. No, I'm trying to actually go into the first septal perforator. So just stay like that. The first septal perforator is much more in the early part. Now give one injection, hard injection. Okay. See, but I think that one is too small. You see, you agree with that? I think, yeah. I think we should go for the second one. So we need to just to increase the curve of the wire. Okay, good. Yeah, see, it lost its curve. And usually you need to give a second curve to help you go into the septal. Roxana, once I get the cross, and then we'll go for the alcohol. Okay, test please. We're almost there. See there? First wire is to hook it. So we're doing what is known as a double curve on a wire in order to get it. Okay, so you have to do this, otherwise it doesn't slip inside. It's got a very bad angle. I'm wondering whether if we advance this balloon will be help you to get a curve. Why don't we change the curve? Let me just take one more try and we change the curve of the wire. Can I get a whisper too? Let's try one chance of hooking this wire. It's straightened out a little bit, right? Somewhere higher up that we're missing it. Just here, second septal perforator. The one I don't want. Almost there, we got it. We're now trying a whisper wire and hoping that we can get through with the whisper wire. It's coming. It sometimes happens. It usually goes in very easily. But then once in a while, you can have a case where you just can't get into the perforator. Test here. Looks very promising. Good. Okay, so let's give 4,000 of heparin. Go to 7.5 frames per second. If I catch it on the other side, catch even the diagonals, it doesn't catch the only other option is to make a little sharper bend. I made it almost a 90-degree bend. First septal perforator is initially what I wanted. But the first septal perforator is too tiny. It goes everywhere but the branches. So which way? He doesn't have a good first septal. So I'm thinking of going to the second septal perforator. Yeah, give him the whisper. Let's make your curve. You have to hook it. You see, it won't go. It's too small a curve. You have to make a bigger curve. Actually, we want to go into down if you can get into. Now, this one I went into. For some reason, it's something weird. Now you're further away. You're too far. You're too down. Pull the balloon a little bit back. We're not in the right plane. Or just make it look upwards and see if it goes. Yep, we got it. Very good. I would come back a little bit, Vishwa, and then turn it to the other one. Yeah. Advance the balloon back inside. Good. Awesome. Now I can pull it back. Go a little bit more in. Okay, stop there. Okay, good. So let me see whether we are in position. So we're going to inflate the balloon now. Go alcohol to this side. Okay, that's good. No, the baseline, yeah, because that's where the muscle is. Yeah, go up till 6. It might be. I'll show you the 6. Go up 6. 8. Okay. You're holding. Okay, so this is very nice position. All right, so stay at 8. Okay, now give me dilute contrast. Okay, just pull it back a little bit. Stop there. Yeah, give me a 3cc syringe, please. So we like to inject alcohol in a 3cc syringe. Okay, let's come back a little bit. Yeah. All right. Okay, so we're going to 8 atmosphere. All right, so I'm just cutting on the wire. Okay, so it's only going to this other branch. I would prefer the other branch. Can I have a BMW wire or a run-through is actually quite safer, actually. Yeah, give me a new one. Okay, so we're going to pull back, deflate the balloon. It moved up. So can you go down a little bit? Advance the balloon. I advanced the balloon. Okay, guides come off. So advance your guidance. I like that position, Pluro. We may be outside, but I'm not sure. Now I'm just going to give some dilute contrast. Yes, so this is where we want to be. Okay, ready for alcohol? Give me 3cc of alcohol now. So what we're going to do is that we're going to focus on the EKG. And we're going to look for widening of the QRS as we give the alcohol. Now 2.5 cc. And I'm getting air in. Ma'am, you're going to get some chest pain. You see the pressures are going up, which is a good sign. So I'm going to go start. And I'm going to watch EKG. Okay, so the LED is open. So we always want to do that. Now I'm going to check another 0.1 cc. Okay, good. And everyone's looking at this thing, and you can see a couple of VPCs. Ma'am, just be careful. Don't move. Can you get the heart rate to, yeah, that's good. And actually see that the blood pressure is fine, right? So it's 134. We started at a lower one. It was not spike and domes. So like 0.1 cc. I'm going to give a little bit more of alcohol. So I'm going very alcoholic, and you can see there's some ST segment changes in lead 3, but the QRS has remained constant, and the PR interval is going to be constant. And you want to develop a bundle branch block. And once you develop a bundle branch block, then that's usually a very good sign. But do you see the aortic pressure going up? So when the aortic pressure goes up, that's usually a good sign. So obviously the LVOT obstruction is minimizing. And look at the QRS ST segments are doing there. So I'm just going to give a little bit more alcohol, and I'll wait again. The LVOT gradient was over 200. And you can see there's no spike and dome appearance. You see that? Well, we'll do a gradient. We can just look at it. We can just do this, okay, and see what the septal's done. So, and if we can get the first septal, that'll be even better. So that's done. Let me go. I'm just going to give a little bit more. We've given 2.5. We've only given literally, I think once. Planning to give only 0.1 cc more, and then I'm going to stop. And then we're going to take this balloon out. Okay, so I think there's no arrhythmic changes, which is really good. Rosanna, you can do. And like basically you do like this, you keep it marinating. Basically, it's almost like it's marinating, so it's fine. And if you can see the bright spot of the echo, see the bright spot is not exactly where I want it to be, right in the base of the septum, 23. So not as bad, but still. All right, so I think if most people agree that I think I should. Can you see the LV 3-chamber view? Usually it becomes bright. And I think it is a bit bright. Yeah, we're done here. All right, so I'm going to stop here, if everyone agrees. I'm going to deflate slowly. There was a PVC. Where's the alcohol? I need to see fluoro just to see the LED open. Okay, is that beautiful? Okay, I'm deflating the balloons very slowly. And I'm going to pull it out. And I'm just going to take this out and throw this balloon away. So the septal perforator is occluded. Right. So the first says clearly the S2 is gone, and we are left to see that. I think if we can manage to get into that, if we can get into that, that will actually be very good. So I would actually go for that before we do hemodynamics. Let's take a 1.5. I don't think it's a 2 balloon. So let's get a 1.5 balloon. Let's take a whisper wire. No, same thing. The lumen's okay. All right. So let's get this. So what we are doing now is we are getting, let's see if you want, do you want to change the curve a little bit? I think I would increase the curve a little bit. Keep going. So we've done this for second perforator quite nicely. We haven't affected any hemodynamics at all. I mean, sorry, EKG changes. We are going to check hemodynamics later. The LVOT gradient by echo is about 22. One of them is done. We're trying to do the other one too. Yeah, it's in a good position. Let's get the whisper there and let's go with the whisper because this will not navigate it down. Okay, so we're in a weird branch. You see the branch? So I wish we can, I'll tell you what, we can advance the balloon. Out of the bed, yeah, this one, of course. No, this one, straight down. I would advance the balloon first, not lose it next time. No, I don't think we are in. It looks like we are in, but it's actually somewhere. Well, the EKG and the right one has changed in lead 1, which is a good sign. Perfect. Okay, so let's advance the balloon. Okay, go a little bit more.
How long is this balloon?
It's only 8 millimeters. Okay, good. Go to 7. I don't want to pull. I hope it's not sticking out. It looks okay. Go 8. Yeah. I just hope that we have occluded. There is Cine. Yeah, Cine. No, yes, it's okay. Cine. Okay, so you are a little bit inside, but the LED, but I think it'll be okay, right? All right, so let's get the contrast 3 cc contrast. The dilute contrast. So we're going to do dilute contrast and see if we can get it in. I'm pulling the wire out. Okay, good. So you saw that? Alcohol went through. Give me that whatever left of alcohol. Okay, and now we're going to inject a little alcohol in. And let's keep pressure on. And can we do an LED injection, please? Just. Okay, good. See, I wonder whether the balloon should have gone more deeply still. No, but it's a bit of the shoulder, the balloon is in the LED. So we're going to go very gentle. Yeah, can I give contrast to the LED and see if the LED is okay? Balloons up. Good. Minimal EKG changes. We were 30 seconds more. Planning to inject 1 cc of alcohol in this. And you notice we're going very slowly, really bright. So we actually got the first septal preferred. That's really nice. You see these beautiful images that she's showing. There's no systolic anterior motion of the leaflet. You can see the leaflet is being pulled in, but the bright spot, and then what happens over time, it actually gets better over time. So I'm just going to give a little bit more alcohol. Same, the gradient is the same, right? I think that's okay, how that is becoming bright. And this will shrink. Okay, I think we should stop. There's a VPC. This was a complex case. This is not easy to do sometimes. And you can see getting the second septal and then getting the first septal is doing the right thing for the patient. I think we should stop here. So you're getting, oh, that's good. Bundle, that's good. Got it. Okay.
Right bundle branch block.
No, left bundle actually.
It's a left bundle.
Okay, so I think we stopped over here. So I'm just going to bring it back. I'm going to take the balloon out. So you want to deflate the balloon slowly. Second septal perforator is definitely gone. The first septal perforator, the side horizontal branch is patent, but the branch which is in the septum is gone. And so we're done over here. We haven't damaged the aorta. And now let's go back to getting a J wire, and we're going to advance the catheter and get some pressure gradients. The EKG has actually normalized now very nicely, but we are going to show pressures. So we're going to take this catheter out. This is a double lumen Langston catheter, which I'm just trying to advance inside. Okay, we got it inside. We are deep inside the ventricle, which is what I want to do, where the gradient should be in the cavity. And now I'm just going to take a pressure reading. I just want a direct pressure tracing. So the double lumen Langston catheter is not always the best side port, but let's see what happens. It sometimes dampens the side. So you can see the gradient has decreased significantly. So call the red LV and call the aorta, PA called aorta. So now the peak gradient is 30. So we started with a gradient of 100. So there is still a post-ectopic Brockenberger phenomena. Which will take some time to, okay, so that's a stable rhythm with some ectopics. So once in a while you get an LV. Now I'm going to pull back gradually and show that in the LVOT there's no gradient. See that? That's all aortic gradient. And ready for pullback? Yeah, this is, you see that? This is LVOT and LV, there's no gradient because it's a subannular. And then you go back right side of the aorta, it's all okay. So now we're done over here. Going to get a wire, and we're going to keep the pacemaker wire inside the neck, and we're going to put a TR band. And so I like to summarize this case. This is a patient with hypertrophic obstructive cardiomyopathy, severe SAM, severe mitral regurgitation, as well as a peak gradient of over 100 and post-ectopic 250 gradient. We did alcohol ablation of the first and second septal perforators. We have reduced the gradient by 50%, and we can show by echocardiography. Roxana, can you show the images, last images? Can you show them? This is I wanted to confirm that we have actually ablated the basal part of the septum. And guys in the camera, just I wanted to show you that, since that was the question asked. Can you just show the septum? Yes. Can you show echo last? Okay, yeah. Yeah, we're going to show the echo images last now, and we want to show you the bright spot. If you see the bright septal spot, which means that is exactly where we wanted to do. And what will happen is that because there's no clear-cut right bundle branch block now, the gradient is not reducing that much. But then what will happen is over the next 6 months, that will get scarred. And once there's scarring of the basal septum, the gradient will drop. The gradient just, yes.
I think the volume of the myocardium
yes.
right now has not reduced.
Yeah, just contracted. That's all it is. Yes.
And with time, the volume.
Yeah, yes, yeah, absolutely.
In that.
Yeah, but I'm very happy that we did the right spot, because this is the advantage of echocardiography, to tell you that you've actually done the right septal perforator. Yeah, and so with that, I want to thank you, everybody.